Hello, everyone, and welcome to CMNCP22, the annual conference of the Canadian Municipal Network on Crime Prevention. My name is Audrey Monette. My pronouns are she, her, and I'm the Director of Projects and Research for the Canadian Municipal Network on Crime Prevention. Before we start, I would like to acknowledge that I am joining you today from the traditional unceded territory of the Algonquin Anishinaabe Nation, colonially known as Gatineau, Quebec. I do want to thank everyone for joining us for this year's conference. It's my absolute pleasure to welcome you to this session, which is titled A New Approach, How Communities Can Better Meet the Needs of People Who Use Drugs. The panel today is going to be moderated by Travis Lupick and will include a discussion with 4 panelists, which we will introduce shortly. And because we want to make sure that every panelist has enough time for their presentation, and we also want to have an opportunity for questions throughout the session, we're not going to be reading the full bios of moderator and panelists. So we do encourage participants to refer to the conference handout or the website. And through there, you can read the full bios and get more information about the sessions and the presenters as well. So without further ado, I am very pleased to welcome our moderator for this session, Travis Lupick. Travis is an author and award-winning journalist who has written for the Toronto Star, Globe and Mail. His most recent books are Light of the Night, America's Overdose Crisis and the Drug Users Fighting for Survival, as well as Fighting for Space, How a Group of Drug Users Transformed One City's Struggle with Addiction. So Travis, thank you so much for agreeing to take part in this session. I'm now going to hand it over to you to set the stage a little bit for a conversation and to introduce our speakers. Thank you so much.
Thank you so much for having me. I'm going to talk more about our speakers in just a moment, but we'll set the stage with a little bit of context first. And even before that, thank you to the Canadian Municipal Network on Crime Prevention for assembling us here. Thank you to our panelists for joining us, who, like I said, I'll introduce in just a moment. The topic we're here to discuss is safe supply, safe consumption, and harm reduction. And so our panel is inevitably rooted in the ongoing overdose epidemic. This ongoing overdose epidemic claimed 1,883 lives during the first 3 months of 2022. That's 21 deaths every day. And this same epidemic playing out south of the border now claims more than 100,000 deaths every year. It makes this conversation one that is sadly relevant right across the continent. This health crisis, which was unparalleled in Canada's modern history until the COVID-19 pandemic, it's a surprise to some people. Our overdose numbers now dwarf even those numbers of the HIV/AIDS epidemic of the 1980s and 90s. This epidemic is driven by a number of factors, primarily untreated mental health issues, income inequality, and a lack of meaningful opportunities for marginalized groups, and the synthetic opiate fentanyl, which is present in the vast majority of overdose deaths today. In British Columbia, which began recording overdose deaths earlier than other provinces and does so in greater detail than most. In British Columbia, overdose deaths associated with fentanyl increased from 4% in 2012 to 25% in 2014, and then 67% 2 years later in 2016. And now fentanyl has been involved in about 85% of deaths every year since 2017. So fentanyl is a big part of what we're going to be talking about today. Fentanyl is a significantly stronger drug than comparable opiates, such as Oxycontin and heroin, which means it's more dangerous. An analogy that's favored by law enforcement is a batch of chocolate chip cookies. When you dole out a tray of 12 cookies, you don't know how many chocolate chips there are in each one. And with fentanyl, if there's too many chips in any one cookie, it will result in an overdose. Fentanyl is so potent that without proper equipment and expertise, it's very easy to make such a mistake and place too many chocolate chips in one cookie. One of the most common questions I've received as a journalist covering this issue for about 8 years now is, why do drug dealers want to kill their customers? Does this not hurt their profits? The answer is that dealers do not want to kill anyone, of course. But the difference in profit margins of heroin and fentanyl are so significant that a transition from heroin to fentanyl is impossible to resist. It's not a matter, when you make the transition from heroin to fentanyl, if you're selling these drugs, it's not a matter of doubling one's profit or tripling one's profit. It's not even a matter of adding a zero to your profits. The difference is adding a whole string of zeros. And so in simple economics means that fentanyl is just here to stay. It's also just a whole lot easier than heroin. Heroin is grown in a poppy field, whereas fentanyl is cooked in a laboratory. And with fentanyl, there are no farmers to pay or field hands that you need to organize to harvest the crop. And instead of smuggling large volumes of a drug over borders in boxes or in crates and hidden in all sorts of things, fentanyl can be mailed in envelopes using the government's own postal system. It's just so much cheaper and so much easier that in provinces, in jurisdictions like British Columbia, where fentanyl arrived first, it's all but entirely replaced heroin. So fentanyl is here to stay as long as the status quo remains in terms of legality, and so overdoses are here to stay. If we maintain the status quo, that is, and we don't have to do that. Vancouver has begun an experiment of decriminalizing drugs and offering safe supply, which is something that I'll let our panelists tell you more about. And to be sure, there are challenging details to be worked out with safe supply, but in essence, safe supply means making a regulated dose of opiates available via the country's healthcare system or a comparable system that guarantees a substance's properties and measurements. Safe supply means you know what you're getting. It means that, if somebody tells you something is heroin, it actually is heroin. It's not cut with all sorts of other drugs or anything from Xanax to rat poison, and it means that the potency of that drug, making it a whole lot safer. That's safe supply. In addition to fentanyl, the question of a drug's legality is one that will also take a central position in the conversation that follows here in a moment. We'll talk about the real-world consequences of making a drug illegal, the many unintended consequences of prohibition, and what alternatives there might exist that could make a difference on the ground in people's communities. When a drug is illegal, its price skyrockets because the price is no longer only dictated by supply, but also by the risks associated with its distribution. It does not cost $10 to produce a point of heroin. The true price is closer to $1 or less, but it sells for 10 times that on the street because the supply is illegal. And with such high prices, combined with the marginalization of people who use drugs in ways that prevent people who struggle with addictions from gaining meaningful employment, what follows is crime. But again, it does not have to, and that's what we'll talk about more today. I'm only going to give very brief introductions now, and then allow our panelists to tell you a little bit more about themselves. But very quickly, joining me today is Sarah Blyth, a co-founder and the executive director of Vancouver's Overdose Prevention Society, which operates a low-barrier supervised injection site in the downtown east side. We have Ronni Nordal, a practicing lawyer in Regina, whose family, like so many families in Canada today, has struggled with addiction and been affected by this crisis. We have Omoregie, a registered social worker with the Ontario College of Social Workers and Social Service Workers. And last, but of course not least, we have Laura Shaver, a longtime activist and board member and past president of the Vancouver Area Network of Drug Users, often called VANDU, which is a collective of people who use drugs who deliver street-level services and advocate for policy change. Laura, why don't you begin by telling us just a little bit more about yourself and your general thoughts on community safety in the context of the overdose crisis? Who are you and what does community safety mean in your life?
Okay, hi, my name is Laura Shaver, and I am a person with lived and living experience. I am a current illicit drug user, as well as I have been lucky to be put onto the prescription fentanyl program, which is awesome in some very many ways, but we have a lot of ways that we have to go. I am a board member of the Vancouver Area Network of Drug Users. I have been now on the board elected 13 years in a row. I am the president of the British Columbia Association of People on Opiate Maintenance. Also, I am the provincial opiate antagonist treatment advocacy navigator to help people to navigate the opiate system that we have. Please let me know if I'm taking up too much time, guys. The other thing is that my thoughts on it is that drug use has been around longer than anything. Methadone actually was pretty much started in like BC, Vancouver. The thing is that we need to have funding, we need sources, because the thing is it costs so much. If this is the only way to make people listen, is that when I was in jail in 2008, I think it cost almost $400 a night for me to be there, when, like Travis said, a point of pharmaceutical heroin costs between like $1 and $3 a point. that's not the only thing. I believe that if you give people are doing the drugs that they're doing because they don't have what they need. I believe that we have designed programs as peers, as partners with, all the different people that have the ability to change policy. And that's what we need. We need policy and we need change, and we need it fast, because the way things are going, we are knowing for sure, without a doubt, by January, 2,000 more of our people, our family, that which is your family and your friends as well, are going to die. And to me, I think that this is a committed crime, almost, of murder. So the thing is that it's not just the people that are using the drugs that are criminals. And I don't think that they are criminals. It needs to be a health service. I believe also that the people who have the ability to make policy are also the ones that need to look at their integrity.
Thank you so much, Laura. Ronni, why don't you go next? Tell us a little bit about yourself and what community safety means to you, sort of in the context of this overdose crisis.
Will do. Thanks, Travis. Hello, everyone. I'm participating today from Regina on traditional lands referred to as Treaty 4 territory in the homeland of the Métis. I respect and honor the treaties made, and I acknowledge the harms of the past and the continuing effect of traumas caused. And I'm committed to moving forward in the spirit of reconciliation, which to me, I believe, requires reconciliation on behalf of settlers and the bringers of colonialism, and I take that seriously. So I want to start by saying I have no expertise. My words are just my personal thoughts and words, and they come from my experience as a mother and spouse of people who have used or are using substances. And also, I hope, as someone that cares about people and has tried to be involved and make a difference in some small way. I am on a variety of nonprofit boards and volunteer with a number of organizations. And that includes organizations working towards opening overdose prevention sites, supervised consumption sites here in Regina, and also an organization that provides abstinence-based treatment. I truly believe that we need to meet people where they are at, not where someone else thinks they need to be at. And I appreciated Laura's words this morning, or this afternoon, sorry. And I wrote some words that are very strong and have a lot of strength and wisdom in them. I just want to start with a thought. Just even the conference title, Addressing Social Challenges to Improve Community Safety. The first thought I came to was sort of, well, who is community? And is everyone included in that term, community? And I think when we look at ways to improve safety, we have to think, are we considering everyone? Because this isn't an us and them. This is, we are all one community. And here in Regina, Saskatchewan's a small province. I think we're 1.2 million maybe. We are on track, unfortunately, for the highest ever overdose deaths in 2022. I think we're on track to hit about 450. And of course, those are the known. And as Laura said, those are people who have lost their lives, and those are families who've lost their family members and friends who've lost their friends. But just as far as words can mean a lot, here in the city of Regina, the city of Regina created a community safety and well-being plan, and it outlines a number of pillars to be addressed. And one they had titled Problematic Substance Use. And I posed the question and I said, problematic for who? And they've actually removed the word problematic, and I'm co-chair of the Substance Use Community Action Table, which is named just like the Food Security Action Table. We're just looking at what needs can we help meet of people who use substances. As I said, Saskatchewan's very small. Until 5 years ago, I farmed in rural Saskatchewan. And in my experience in rural Saskatchewan, there's still very much a view or a pretending that drugs don't exist in rural Saskatchewan. That's an us and them thing. I think Saskatchewan's a very different entity than some, than BC or Ontario. We're behind. In Saskatchewan, we have lots of nonprofits that are trying to make a difference. There's not a lot of communication. There's not a lot of collaboration. And I like Laura used the word navigation. Individuals have to go to each organization often, start the questionnaires, fill out the applications, jump the hoops, and then they have to go to a different organization for food, a different organization for shelter, a different organization for methadone or Suboxone, a different organization for treatment, a different organization. There's only one supervised consumption site in Saskatchewan and Saskatoon, and there's one overdose prevention site in Regina. They're open limited hours. We have no 24/7 warming shelter or gathering place here in Regina. We have limited ability for people to test their drugs here in Regina, as everywhere. Huge housing crisis. Last winter, we had Camp Hope, which was a tent encampment, which was ultimately taken down when the city and Ritz's put up a temporary shelter. But that closed in March of this year and has not reopened. And we now have a number of smaller tent encampments, and we've had 3 blizzards so far as of November 8th here in Regina. Our services are mainly only open Monday to Friday, 9 to 5. And most services have significant rules of eligibility that people must follow to participate. And it's kind of like, my kids had this red and blue game where there was shapes cut out and you had yellow shapes and you had to put the square yellow piece in the square hole. And it seems like many of our systems are designed that you have to be that square piece or you don't get in. You have to fit the mode. So I think most of our systems in Regina or Saskatchewan are based on assumptions made by someone else about what the right outcome for people is and what the right path for people is, instead of thinking at, for today, how can people who use substances be safe so they have a tomorrow?
Thank you, Ronni.
Yeah, thanks.
Osi, why don't you go next? Tell us just a little bit about yourself and how community safety appears in your life.
For sure. Thank you for having me. My name is Ose. My pronouns are she, her, elle. I am located in Ottawa on unceded Algonquin territory and Anishinaabe territory as well. I am a social worker. My experience and background is in addiction counseling, in residential treatment programs, both harm reduction and abstinence-based. I also work at Upstream Ottawa, which is a community mental health support agency. And I work as a social worker in our SAPAC program, which provides mental health and substance use support for Black youth between the ages of 12 and 29. So we do addiction counseling, we do individual counseling, and provide a various level of different supports for Black youth and their families. And I think, following Ronnie's introduction, I think it's best that I go next because I really do fundamentally agree with what she's talking about. And when we talk about community safety, it's really important to center the discussion around who are we serving, who's most affected by this. I think overdose and substance misuse doesn't discriminate, right? So it can affect anybody despite what their ethnic, cultural, or racial origin is. And I think a big part that we're missing in the conversation is really making sure that we are servicing people regardless of race and really serving underserved populations, marginalized groups that, may not get access to the same supports, specifically the Black community. I think it's really important to go to places that we haven't gone, right? Providing supports in different communities and areas where Black youth frequent and other Black folks. I think it's really important to ensure that the work that we're doing is intersectional, the work that we're doing is equitable and diverse, and making sure that we're not just serving one population. A lot of the numbers that we're seeing for overdose are the ones that are reported. And there's a lot of numbers for people who who unfortunately experience overdose and don't get reported and get lost in the conversation. So I think it's really important to look at agencies, and when we talk about community safety, looking at a lens of even data collection. Is your data being collected at the intersection of race, right? Is your data being collected at the intersection of vulnerable communities? What does your agency stand for? What are the ways in which you commit to serving communities that are Black and racialized? What sort of approaches are you adopting that are culturally responsive and culturally literate towards communities that we're not always seeing at the forefront, right? So looking at who we're servicing and how diverse that population is, because again, overdose and substance use doesn't discriminate, it affects everyone. So if the numbers are only showing a specific group, well, then we're looking at who else are we missing. So that's something that I really value, especially working with different populations and really making sure that we're providing equitable care. And that really comes from, self-reflection in terms of, as a worker, as a service provider, as someone involved in government and politics and policy, what are ways that we can contribute to ensuring that we're serving the most amount of populations and that we are ensuring that we're serving Black individuals, and also committing to that action. Sometimes I'll work with an agency, or our agency will partner with other agencies, and on the website they'll commit to saying, we service Black populations, we service Indigenous folks, and that's the center of our programming. And then we'll say, okay, where's the data to reflect these individuals? And they'll say, well, that's what we're contacting you, right? You're a Black agency, you service Black communities, and we think it would be a really good move to work with you, which that's not true, but I think it's really important to say you need to develop that internal capacity because we're talking about saving lives, right? And we want to make sure that we're saving all lives, not just a specific group. So that's the lens I'm bringing, and that's the lens that I navigate my work. And when we're talking about community safety, I just really value making sure that community safety is intersectional, and that harm reduction support serves everyone and not just specific groups.
So thank you so much. And Sarah.
Hi, I'm proud to be here today on traditional Musqueam, Squamish, and Tsleil-Waututh land, and presenting here in the downtown east side in a time where community safety is like a huge topic in politics, but also just day to day on the street with all of the tents that have come up on Hastings Street where I work at an overdose prevention site. So I guess I'll start with in 2016, we opened the first ever overdose prevention site. It was a grassroots initiative that we opened due to the increase in overdoses that we were seeing, and worked with Travis, who reported on it at the time. And we started with a GoFundMe page because the government didn't support what we were doing and tried to stop us in different ways. And we just said, well, we can't sit here and watch people die. We're not going to sit here and watch people dying. So while we're doing other things, working in the community. So eventually the government supported us. Now we're 6 years in and we're still in the middle of a crisis, and it's, the numbers just came out yesterday and they're worse than they ever have been. And the drug supply is worse than it has been, not only in Vancouver, but it's across Canada as well, in different places, and even in the States and other parts of the world. Fentanyl is just so easy to distribute compared to heroin, and so it's just taken over the market. And there's other additives now that have made it even worse. So it's a really difficult time. With COVID, I feel like there's more people living in poverty than ever before because a lot of people lost their incomes, or a lot of businesses went out of business. And so it's just creating a bigger poverty divide, and putting a lot more people at risk of everything, including homelessness. And we're seeing bigger lineups with homeless people in the lineups coming from different parts of the city to access programs that service people on the downtown side. And there's just more people, coming to access services just based on there's not enough services in other communities. And so it's really difficult because I feel like the divide of people in poverty is getting a lot bigger. And it's a terrible, terrible, terrible situation. And, we just had a Vancouver's Dying documentary, and I hate to promote it, but it was brought together by the local police and some development funders. And what it's done is it's just created this false narrative around connecting crime to homelessness and targeting people, and so more and more hate come to people that are experiencing homeless, and all while we're having more people homeless than ever before, and rich people are getting richer off of this narrative as well. So, and paving the way for them to do the things that they need to do to become rich, while we don't feel any sadness for the poor people that live in the world. I don't know if that
Thank you,
makes sense.
Sarah. No, it does. Perfect sense. Inequality. I mean, that's at the core of so much of this.
Yeah.
As we move into the real Q&A portion of this panel here, I'll ask panelists to keep your answers to the following questions kind of in between 2 and 3 minutes, just so that we have enough time to let everybody speak on as many topics as we can. The first question I had was kind of to lay the groundwork for what we're talking about here. We say that addiction is a disease, and we say we can't police our way out of this epidemic, but a lot of people still believe that even hard drug use is a choice. What would you like people to know about drug addiction? Ronni, would you like to go first?
Sure. I guess for anyone that thinks it's a choice, watch someone you care about be sick, be drug sick, become someone else, and I mean, it's just kind of actually talk to people and realize that we're talking about people. And I think it's that the addiction and the influence of the drugs that have been used means it's the drugs talking, it's not the individual, and it's not a choice, not a choice once you're to that point. And again, it's not my experience, but I think, get informed. Don't use Dr. Google or whatever it's called. Be informed, talk to people who actually know, and don't believe everything that Facebook tells you. So I think it is an illness, and so substitute the word cancer or diabetes or substance use, disorder, or for addiction, and then say the statement again, and then really think about it. I'll leave it at that.
Thank you, Ronni. Osei, what about you? What would you like people to know about addiction?
I would like people to know that addiction is a response to pain. And a lot of the time when we're doing addiction counseling and treatment, a lot of the work is trauma work. You can't do addiction counseling without trauma recovery. So really understanding people's stories, understanding that people are beyond the substances they use, they're beyond what you're seeing in front of them, and also remembering not to diminish people's capacity. As I said before, addiction doesn't discriminate, and substance use doesn't discriminate. So anyone, can develop an addiction, and it really, really is such an important topic. And it's not enough to just say, addiction is a choice and leave it there. I mean, people's lives are at stake. People are dying because of this issue. So it's really important to really educate yourself and have conversations with real people. It can be very, privileged and comforting to sit in your home and not interact with people who experience this, to not know anyone who does, and have a very privileged opinion about, what it means to experience addiction, what it means to experience drug use. So for sure, I think education and really connecting with people person to person, I think is important. And yeah, that can really help to dismantle the idea that, addiction is a choice.
Thank you. I think education is such a key word there. Sarah, what would you like people to know about addiction?
Well, I mean, like what people don't understand, and a lot of people who use drugs use them based on pain and trauma, and it's not as simple as just walking away. And some people will need to use drugs in one form for the rest of their lives, and a lot of people that I know that have schizophrenia use something like fentanyl or whatever they can get on the street because it works better for them than the medication they're getting from their doctors. It's easier. You just walk out the door and there's someone. It's simpler than that. And so it's just, and I know from experience because my dad used drugs as well. And, he would go and get some medication from the street because it was just easier. And what's changed is the toxic drug supply, and people are it's the talk. I mean, we have to think about it's the toxic drug supply that's changed, and not people necessarily using, and for the reasons that you use, it's different. And a lot of people who are dying are just people that go out and use fentanyl by mistake without knowing as well.
Thank you. You said your father used to go and get some medication from the street. I think that's such a key part of this. The fact that so much of this opiate epidemic is people self-medicating. We saw a huge increase in deaths when doctors actually clamped down on prescribing drugs like Oxycontin, which is counterintuitive, right? You'd think if they gave out less drugs, there would be fewer deaths. But because people were medicating with those drugs, when the doctors stopped giving them out, people didn't just stop using by that point, they were addicted. And so they went to the next best supply they could find, which happened to be heroin on the street. Laura, round us out here. And what would you like people to know about addiction?
Sorry, so I believe, I'd like to echo a lot of things that were already said, is that drug consumption is a health issue, and what people need to know is we are not numbers. We are people that have heartbeats and bleed the same color. People would be very surprised on who the people are that are consuming drugs, and when the people say, when we're saying that we're losing our family and our friends, actually the people that we're speaking to make policy. You're also our family and our friends, and you're losing your families and friends. Pretty soon, if there's not change made soon, there will be nobody to ask for change. We've given the maps that are, I believe, that are needed and can be supported. There are so many different types of quote treatments that could be done. I believe that this is how can you have a medical crisis that lasts 6 years and it only goes up? To me, there were more people dying of fentanyl overdose than there was of COVID, and now fentanyl overdose deaths is the #1 reason for death. And to me, that they're preventable deaths. All of them are. And that's the thing, is I cannot stress enough that yes, there are programs, but people can't access them. They're only accessible to a certain amount of people and in certain places, which makes it sometimes feel like, well, how come they deserve to live and I deserve to die? We need to make policy. We need to make with decriminalization, we need legalization. We need to make it an actually a reachable goal. When you decriminalize it, such a small amount of drugs for people to consume, they have no choice but to go back onto the street. And to me, that feels like it's known. It's known by the professionals that have the ability to change these things. So to me, it feels almost like I hate to say it, but it's like a decimation of people who they think are those people. But when, to me, the difference is that I just don't lie about my drug addiction or my drug consumption, because if I feel that it is no longer, it's no longer a choice of if I might die if I use street drugs. It's when. There's no if anymore. It's when. When you have statistics of 6 people dying still a day, hey, that's way too close to home. And the one thing that I have to stress extremely is that there needs to be communication, way more communication between the people that are using and the people that are prescribing the drugs, or the maintenance, because there can be some really damaging effects, but there can also be some really good effects. The thing is I just think that people need to get off the fence, get off my feet, your feet, Sarah, Travis, and stand on your own and realize that this is not just a your problem. It's affecting the world, everybody. It's the number one thing killing now. Come on now, you guys. The people that I know work just as hard as, or harder than people that make $100,000 a year. They do more time. They go through more trauma, and they're not acknowledged enough. I work with heroes every day that save lives. We have now had a police officer parked right outside our doors of Bandu, not yesterday, but for the 2 days prior to that, threatening, even to saying that he's going to come in every day until he gets what he wants. Well, you know what? I'm betting that every day he sits out there, there's a possibility that somebody is dying because of it, because they are scared to enter the zone, because there are police there, and not because they're scared because they're carrying too much drugs or they're doing. It's because, like myself, I'm institutionalized. I haven't been in jail, had anything to do criminally with the cops since 2008. But the second I see them, I sweat, I shake, and it's because of what they have done to me in previous times, because of the ways that they have treated me in previous times. And this is not me. My story is not. There are so many people that this is affecting, and
that reminds me of something that Ronni said earlier. Who is community? I think that's a question worth getting into a little bit later.
Everybody.
How do the second question I have for everybody here is, how do you see the war on drugs and prohibition play out in everyday lives, in your everyday lives or past experience with someone who's been affected or who has interacted with the overdose crisis? In policy circles, these things can become a little esoteric, a little intangible. How does the war on drugs and prohibition actually play out in front of us? Osa, do you want to go first?
Sure. I think, again, and even going into, what Laura spoke about, if you're not seeing it, you can become very blind and very numb to the real reality of what's been going on. I worked in shelter in addiction residential programming during the height of the pandemic, and we were never more busy with the wait list, with people calling us crying, saying, I need help today. And, there's always limitations. We only have a certain amount of beds, now because of restrictions, we can't let people come in. So it's a powerful thing. And I think, even going to what Laura said, how do we change this in terms of, as she talks about her experience, scared to interact with police or not going to areas where they are, right? And that's a big component, because right now, if everyone was doing it amazing and we were all getting it right, we would see this number decrease, right? But we're only seeing people who are sicker and sicker. So I think it's really important to look at, community trust, and recognizing that the people we're working with are institutionalized, and that there's extra work that needs to be done to build that rapport, to build that trust, to build that safety between service providers and clients who are seeking support, seeking help. Because again, we're seeing increase. I think within COVID, we're seeing a lot of increase in overdose because people are isolated. They're using by themselves. They're not using in groups. We're seeing people who, even as people are dealing, they're cutting drugs with other things because it needs to stretch, right? COVID posed a lot of barriers in terms of shipments that people were getting, especially when borders were closed. So we were seeing a lot of that, a lot of accidental overdose. That was a big thing. I know myself personally, I know at least 4 people who have passed within the last 2 years due to accidental overdose. So I think when we're talking about the war on drugs, the big part that we're seeing right now is accidental overdose due to people not being able to see what's inside of the things that they're using, not having clean and safe equipment. So yeah, I think that's a big part of the war on drugs is what's not seen, what's not reported, and also people being uncomfortable to engage with this topic. I think that a lot of the times we hear a lot about, naloxone, we hear about kits, we hear about, overdose, we're hearing a lot about fentanyl, but what does that really mean? Like beyond the buzzwords, what does engaging with this community mean? What does engaging with this topic truly mean? How do you provide equitable supports? And how do you reduce barriers? Right. So the war on drugs is a very loaded topic, but yeah, I think that's a good start in terms of, what we're seeing. And personally, I would say it's a lot of accidental overdose.
Thank you. Sarah, I know working in the downtown east side, you must see the war on drugs right in front of you every day. What do you see?
Well, I mean, obviously the war on drugs has been a failure. And I feel like we, because it's just the thing that, we've been rolling out for hundreds of years, it's been so hard to, incrementally change that focus of the war on drugs to something that's more compassionate, like a more compassionate response. And actually helping people and, taking them out of the criminal system and, and getting them the help and support that they need, which would in the end be cheaper than going on and on with this war against, vulnerable people. And I feel like it's just election after election, politics in the way of helping actually change things so that we're, creating community and not stigmatizing people to the death of them. And so, yeah, I mean, the war, it just continues, small things like decriminalization and, like small programs of safe supply, but nothing's like incremented quick enough with enough powerful force that it's actually changing the end result, which, and then people say, oh, well, you're doing safe supply and you're doing all of these things and it's not working. Well, no, we're not doing enough of that to change, the direction that we have been going in with the war on drugs for so long.
Thank you. I like how you reframe things from the war on drugs to the war against vulnerable people. I think that's something that's kind of forgotten, that the war on drugs is not a war on drugs. You can't wage a war against an inanimate object. This is a war on people. Ronni, if you could go next, how do you see the war on drugs play out in our everyday lives?
I think when I hear war on drugs, I think of the Reagan years in the US and the Just Say No campaign. So I think it takes us back to the first question. It takes away the fact that substance use disorder or misuse is an illness. It's not a choice. And the Just Say No was back in the day that, it's just a choice, just say no. And, Laura started us off by saying that people who are doing drugs are using because they don't have what they need. Sorry, I wrote it down as a quote from Laura. And I think, like Sarah said, war on drugs takes the focus away from making the policies and giving the people what they need, be it food, housing, safe supply, treatment, drug testing. The list goes on, but we don't have to do that because we're focused on, we're doing the war on drugs, look at us go. And I think we have to shift that focus to giving people what they need at the point in time, whatever it is, wherever they are.
Thank you. The next question I had is in a similar vein, but kind of takes the next step. What would an end to the war on drugs look like in your life? What, in a tangible sense, in a way that you can actually feel it in your everyday life, what would an end to the war on drugs mean for you? Sarah, do you want to go first this time?
Sure. I guess, people in housing, getting medical help as they need it, people living in poverty, people with mental health issues, getting proper support that they need. That's basically what I would consider is just people living normal, healthy lives, not being stigmatized and judged for using drugs. Mostly everyone I know uses some sort of drugs. It's just a matter of not stigmatizing people who have who also use drugs. So it's just, I guess that's what, I don't know really what I'm getting to the point of here, but yeah.
You said mostly everyone uses some sort of drug, and I think that's really true, whether it's a strong headache medication or Adderall, and then you said it's a matter of not stigmatizing people for using certain drugs. Talk a little bit more about that then, the effects of stigmatization.
Yeah, stigma is one of, people go into, for example, someone will go into rehab and then come out and then use again, and they'll use alone frequently because they're afraid of, what people think. A lot of people, stigma, in their family and stigma in their communities really does kill people. It's just, there's no two ways about it. And so,
that's a powerful note to end this question on right there. Ronni, what would an end to the war on drugs look like in your life?
I think it would see the focus, we'd actually have resources put into providing people with what they need at the moment. And that would mean that when I sit down and have a conversation with someone, it wouldn't start with they don't have anywhere safe to sleep that night. It's coming the weekend, so there's nowhere to get food that weekend. The best safe measure is to have Narcan with them, which is a measure, but it's not a treatment, it's an intervention. And I think sometimes some people have fallen into the thought that Narcan's suddenly a treatment. It's not. And I think it would see people have hope. And once you have hope, as Sarah said, then there might be change. Who knows what it might be for everyone's different, but everyone can have a better tomorrow than today, whatever that better might be. And I think that would be the difference I would see.
Thank you. Ose, in your daily life as a social worker, what would it look like if the war on drugs ended tomorrow?
It's almost utopian to think about it, but it would really look at kind of going back to what Ronni mentioned about people having their basic needs met. I think specifically if coming from working in shelter, really adopting a housing first approach, I think is one of the biggest things, right? Even when you're looking at treating, working with someone. A housing first approach is essentially talking about ensuring that everyone has shelter and that everyone is housed, and that will mitigate a lot of issues that a lot of people are experiencing. I think safety and security is a big thing, and especially a lot of people who use substances are escaping a reality, right? They're trying to escape pain, a trauma, their certain situation, things of that nature. I think if we address some of those things, if we address the poverty, the food insecurity, the safety, like all of those things, then we'll see a big reduction in overdose and drug misuse and things of that nature. Tomorrow, it would really look like a lot of service providers who look like me, to be honest, really incorporating a lot more diversity in terms of who we're serving, right? The staff that are helping people need to reflect the community, and the community is very diverse. And I think specifically in Ottawa, if we see an increase in that, I think we're going to see a lot more people accessing care, right? Because a big part of the war on drugs is reducing barriers to care. I know there was even a study that came out from the Mental Health Commission, and it was a study on Black communities throughout the pandemic and post. And it was reported they did a study with over 300 Black community members, and it was reported that 60% of them would prefer and would actually access mental health care if the service provider looks like them, if they could relate or resonate with the service provider. So I really think mitigating some of those barriers to care simply through intersectionality, diversity, cultural literacy, I think those are key components. But again, really addressing those basic needs, housing first, making sure everyone has a meal to eat, somewhere to put their head. I think just that little bit of safety really helps individuals who are using substances.
I'm really glad that you mentioned housing first. There was a really interesting informal study done in Vancouver in the early 1990s where a woman named Liz Evans was moving people off the street into a supportive housing site, a hotel. And on their way in, she asked them, how many addresses have you had over the previous 12 months? And the average number was 11. So these are people who were being evicted over and over again every month, primarily evicted for some sort of a mental health outburst, a disruption, or drug use or an overdose or something like that. And Liz incorporated housing first policies into this hotel where she told people, this is your home, you're going to live here now, and you're not going to be evicted for a mental health issue, you're not going to be evicted for using drugs. And she was just trying to be kind. This was kind of before housing first even existed as a policy, but she noticed this really neat unintended consequence. She told people, or when she told people, you're not going to be evicted for using drugs, you're not going to be evicted for mental health outbursts, they had used fewer drugs and they had fewer mental health outbursts because that stress, that chronic stress had been removed. And I think that's what housing first does. It allows people room to breathe. Our next question, time for the $1 million question. How do we reduce overdose deaths? I know that we've touched on different pieces of this throughout, but let's really get at the question specifically now. This is next to COVID, the greatest health crisis that Canada's faced in modern history. How do we end it? Ronni, take us away.
Oh, shoot. I guess we actually put our resources into, I think it was Laura that said, COVID pandemic, and we shut the country down and figured out how to address it. Well, to the point, we need to put our resources in the right places, listen to the people with lived and living experience of where those resources should be instead of, other people that have no idea making decisions. But I think also making sure those needs are met immediately. I mean, I was talking with someone on Friday night who's, actively using and would like to reduce, and so would her daughter. But she says, if you told me you could get me assistance tonight, I'd go and my daughter would go. But tomorrow afternoon, I know I will, it will be different. So whether that's treatment, whether that's counseling, whether that's food, it has to be immediately accessible, no matter who you are, where you are, and when it is. And I think that's how we, the stigma has to go, because then it truly is. If you're a cancer patient here in Saskatchewan, you have a navigator. We need to have a navigator to help people through the systems and to make sure they see tomorrow.
Thank you. Laura, let's try your audio again, and if you can make sure that your speakers or anything like that are turned off. Laura, how do you end the war on drugs?
Well, I guess it's you would meet people where they're at, and you need to have the people that this is affecting be the ones that are making the policies and the change. Because the thing is that if it wasn't for us pushing for things wouldn't happen. So say if we didn't have the the organization advocacy here at Vancouver Pump, people would still be getting money taken off of their disability or welfare checks to pay for their private clinics. I think that ending the war on drugs means you need to do just more than just giving somebody a safe supply. Because once somebody is off a street drug or off doing criminal activity, then what are they doing with the rest of their day?
We'll try returning to you again in a minute, hoping that things clear up. I'm sorry about that. Ose, how would you resolve this crisis?
Sorry, can you repeat the question?
How would you solve the overdose crisis? I mean, I think, with someone like you who has been in this for so long, it's going to feel obvious, but tell us, how would you solve the overdose crisis?
I think preventative care is really important. I think as it's hard to say, it's not a single solution type of thing. It's really layered. But I think it would start with preventative care and, really engaging and educating people about what drugs are, what drug use is. Some of the, pointers out and some of the indicators for addiction, and starting it younger, letting drug use not be such a taboo topic and talking about it earnestly and honestly. And I think that we're beginning to do that. But I think it should expand beyond, the communities and agencies that have been doing the work for so long. I think it needs to touch every corner, every area. Again, I think adopting a housing first model across the board would really help to mitigate the crisis. But again, it's much of a larger issue. It comes down to funding. It comes down to physical space, right? It comes down to, inflation and making sure that people aren't food insecure, and making sure that people have the resources to sustain a livable life. I think that's a big part of it, right? And also on the medical side, I saw in the chat someone was talking about, chronic pain and those who are using substances in a response to chronic pain. That's a whole other conversation too, right? About, looking at this is my real reality. I'm in pain every day, and how do we resolve this? What are all different alternative methods to healing? How can we advance medically to ensure that we can respond to pain in a different way, in a way that's effective, in a way that doesn't leave someone with, maybe this issue is gone, but now I have pain for the rest of my life. So there's different areas to it, right? But again, I think it just comes down, honestly, to having people's needs met and being able to mitigate some of the barriers to people accessing care. I think those are the two biggest components, because again, it data collection, it comes down to trust and safety, right? If I don't trust your programming, if I don't, feel comfortable, right? You're asking me to be really vulnerable. Like, let's be real about that part as well, right? So we're urging people to access care, but then you're asking them to talk about something that's very private, something that they've been dealing with probably by themselves for a really long time. So really centering that, owning that, acknowledging it, and using that as a framework to say, okay, how do we base our approach to care? How do we connect with community? How do we connect with vulnerable individuals, right? How do we mitigate, and how do we respond to trust? How do we build community trust and community rapport with groups that aren't already there, right? Sometimes, location is inevitable. I know one of the shelters downtown is right at the corner. There's an LCBO, and they have so much addiction programming there. And we talk about it all the time as such a risk. But sometimes when we talk about, addiction recovery, one of the things we say is, yeah, you're in treatment, right? And this is an isolated environment where, you can focus on yourself. But when you get back into the real world, there's triggers everywhere. There's ads, there's triggers everywhere. You can't control that, right? So really helping someone to function on a day-to-day basis. I think would really help to respond to this crisis. I think it's important to always be reflexive in our work, in ourselves, in our agencies, to say, what are we not doing? What can we do better? How can we improve? That constant thinking, that constant acknowledgement of, okay, we've done this so far, so what else? What else are we not doing? And, really developing those communities of practice to discuss, we've been doing something the same way for 20 years, it's not working. And I think that's the really big important part, because sometimes, this field, it moves so quickly. There's so much new information, the terminology changes. And I think staying up to date, staying on top of that is really important to effectively help people. So yeah, my long-winded response is there's not one single answer. There's a lot of factors that would contribute to that. So yeah.
That was excellent. Thank you. And then Sarah, we'll let you give us the final response for this $1 million question.
So, I see, I talk to a lot of drug users about various things. And I think, some of it, the prevention aspect would be talking to kids while they're young, making sure that kids that have ADHD get on, safe, some medication that will help them, and getting youth the support that they need, but also educating young people about drugs, and not just, just like we did sex education during the HIV crisis, letting them know about what the risks are, what different drugs are, all of the different things, and where they could get help, and creating some of that, but also not allowing people to fall through the cracks. We need housing. When people don't have housing, everything becomes more difficult. And so I think making sure that there's sufficient housing for people would be, a good start to the end of the actual crisis is housing. And also safe supply is so important, just in terms of just getting, even the VPD and other police departments agree with this, that safe supply would really take the criminality out of it, and make it, it's a medical situation, and that people should be helped the way that they need to be helped. And I think, the crisis ends when people are getting sufficient help they need. They're in housing, like people should be living lives that with, not having to worry about, living in a tent outside. I can't imagine everyone would use drugs under those circumstances and conditions, right? So it's just, I think, the end of a crisis would mean that people, are living quality life, using drugs or not, and supported as youth, and supported by the government, and with a safe supply of drugs that won't kill people. And I think until we get there, I think we're not doing enough. And so I just worry that the divide is getting bigger between poverty and richness, and the rich people are good, rich people win campaigns and elections. And I feel like we're going to get further and further down the road of the wealthy versus poor divide. And I can just see the anti-poverty campaigns that are going on right now. And I just feel like we're stepping backward, and it's going to be a rough go. That's what I think.
Housing first, inequality, stigma, and attitudes of the healthcare system, policing, etc. These are things that have come up in just about every response, I think, that people have said throughout. And I think that means that if we're going to resolve this overdose crisis, if we're going to make communities safer, if we're going to end the war on drugs, we really need holistic solutions, things that really touch a lot of different areas. And that's very challenging. That these are not easy problems, but I do think that they're problems, that they're systems that we can change, and these are problems that we can solve. Thank you, panelists, Sarah, Ronnie, Ose, Laura. I really appreciate you guys coming out here, sharing your thoughts. Thanks to the audience, and I'll turn it back over to CMNCP and Audrey for a final goodbye.
Awesome. Thank you so much, Travis. I think I'll just echo all the thank yous. Thank you to everyone who joined us for the conversation, who asked questions. As we said, feel free to connect offline with the participants. Thank you to the panelists for sharing your experience, sharing your thoughts. Very much appreciated. I learned a lot, and I look forward to continuing the conversation afterwards. So thank you so much, everyone.